Not bad. That's not bad. And more will be coming.
You know. Yeah. Yeah. That's good.
I'll try again. Good morning, all of you. Dear ladies and gentlemen, my name is Frederik Folke and I'm part of the local scientific committee at the EMS conference. And it's my privilege to welcome you all to this last day of the EMS conference. It takes a system to save a life. And new to me is apparently it takes that exact same system to launch a great party. So yesterday Freddie told us that we should dance quality dancing for at least 30 seconds. And as 30 seconds for at least. And I think it says something about some of our dancing skills that we had to try to 2 hours before they closed and threw us home. Well, I hope you have had some really good days at the conference here in Copenhagen. And before we can say that this has been the best EMS conference ever, there's fortunately still some really nice talks today, poster walks, and breakout sessions. So before we start the key lecture, I would like Paul to say some practicalities.
Okay, so congratulations, you all made it back this morning. Looks like one or two of your colleagues didn't, so well done. Can everybody remember a few things? So the scavenger hunt is still ongoing. The big prize, so make sure you visit all our sponsors and try and find out on the scavenger hunt to win a prize. Later on this afternoon as well, we will have the EMS Leadership Award, which is a very special award. We talk about it takes a system to save a life, and the organisation or the person who really exemplifies that and works towards that will receive a special award. As you've said, there are some great sessions today. You know, it's sad that it's coming to an end, another fantastic Congress, but I think it's really important that we enjoy today and get the most out of it as well. Frederick?
Yeah, I would like to invite Torben Wisborg to the stage to introduce our keynote speaker of today.
Thank you and good morning, everybody. I'm very thankful that I've been allowed to introduce Tanja Manser to you. Tanja is one of the leading experts on team performance in healthcare in Europe. She's been working in Europe and in the United States. She's now a full professor in Bonn, but she's also a relation to Norway as she's an adjunct professor at the University in Stavanger. And she still has connections to her old institution, the Swiss Federal Institute of Technology in Zurich. But she has a long history with Norway. This is a picture from Bergen, 2005, when she was returning from the United States. She went through Bergen to give a lecture at the Best Network meeting. I'm an associate editor of the Acta Anesthesiologica Scandinavica. And on our homepage, we have a sort of a wall of fame, the top 10 most downloaded articles during the years. And it's funny, but not a big surprise, that the most downloaded paper in 2016 was actually a paper written by Tanja Manser. And it was published in 2008, and it's still on the top of the most downloaded papers. So this is a significant paper. If you haven't read it, I suggest you read it. As you can see, it has so far been cited by 213 other papers. So it is an important paper. So by this, I would like to invite Tanja to the stage and to give you a lecture. Please, Tanja. Good luck.
Thank you. Good morning. Thank you for the kind introduction, for the invitation to be here. It's a real privilege to give this keynote presentation. It's on high-performance teams, and I think that's an expectation in many care settings, especially in medical emergencies, that the team is actually performing at the best level. But I think there's always areas to improve, and there's always questions how we can do it. So I want to talk a little bit about why we should focus on teamwork, why it's important, and then just go through some ingredients of a high-performing team, just to give you a few ideas, what you could include in your training, what you can work on in your own clinical practice. But then I also want to talk a little bit about aspects of debriefing and clinician support and maybe the way forward. So generally, healthcare is very team-based. You work usually with people from different professional backgrounds, with people from different specialties, and it's quite hard sometimes to integrate these different professional cultures. And when we look at critical incidents, no matter in which care setting, we always find that people say, oh, the teamwork should have been improved, the communication wasn't that good. But it's quite unspecific, so we just know improve teamwork, communicate better. It's not really something that you can implement in your training easily. And there are now more and more papers coming out that study teams in different healthcare environments and try to tease out the specific behaviors that we can include in training. As I said, there is a lot of studies from different settings using different data sources that show that in about 30% teamwork played a role in a critical incident. That doesn't mean that if the teamwork is poor, the patient will die immediately, directly, just due to this teamwork error. But just poor teamwork makes things slower. It makes people less likely to communicate. It may delay the treatment. It may make things a little bit, or other things a bit more tense in the team, so people are more likely to commit other errors. So that's no wonder then that teamwork and communication are important contributors. But it's also when you talk to healthcare professionals about patient safety, I think it's quite interesting that teamwork is the word they mention most. And they talk a lot about teams, improving teamwork, who is on the team, who do I see as part of my team? Am I just on the nursing team, or are we actually an interprofessional team? And I just want to illustrate it with a few quotes from an interview study we did in intensive care. And this person states that it's simply because of the great team climate that after 9 years I'm still motivated to work in this wonderful profession. And when you think about it, in most professions outside healthcare, 9 years working in that profession is not a long time. But in healthcare, people drop out really early, and good people leave the profession because of oftentimes a poor team climate. People describe working in a team as stressful when there's mistrust and competition and also territorial behaviors. And I think in emergency medical services, there are some well-known lines of conflict, for example, between the ambulance and the air rescue team. There are often frictions that can make it very stressful. But it's also that when the teamwork goes well, you can access your best performance more easily. So everyone can bring their talents to the table. And if there's conflicts, if people are not getting on, then it decreases the performance of the whole team, not just of the people who have a conflict, but actually everyone. So what are the things you need in a high-performing team? Generally, it's good if you have a clear idea of what you want to achieve as a team, if you have shared priorities, and if you have clearly defined work roles, responsibilities, competencies. So that's something that can be done before you actually start working together. Then, while you're working together, I think it's really important that the leadership responsibility in these teams is shared. So if somebody fails to step up and take a leadership role, others can support this person. It's not just assigned to one person. Actively participating in briefings and debriefings. It's not just people showing up for the briefing, but it's also actually paying attention and contributing what you know about the patient. And then also being allowed by your organization, being allowed by your peers to make decisions when they're needed and where they're needed. That you don't have to go up all the steps to ask for someone's permission, but actually that you can act in a dynamically evolving situation. And then also collaborating across boundaries, across functions, across professions. That's something that we often don't include in training. So if you train people separately in silos, it's very hard for them to appreciate the competence of others once they work together. And then, of course, there's this team atmosphere. So how do you handle conflicts? How do you maintain positive relationships? This requires effort. It's not something that just happens. So we have to actually be heedful and think about the needs of others. And maybe in the briefing you heard that your colleague has some health issues. So you can be a bit more supportive, or you can just say it's not my problem. Another thing that really helps is if you have clear performance measures. That's really difficult in healthcare. But even in areas where we have these performance measures, there's hardly ever an immediate feedback. And we were talking yesterday about the lack of feedback from the emergency department to the pre-hospital team. You know, what did you find afterwards? How could they improve? What was helpful and what was actually a bit off looking back? And then also what we see in high-performing teams is a passion for the work you do. You actually have to like working in this team. If this is a constant hassle, if you constantly hate working with this other profession or in this environment, then you're never going to be performing at the best level. So what many of you certainly experience in your daily work is that a team is not the same as any other team. So there are teams that work together better, where you like being part of the team. And maybe these teams have certain characteristics, but generally, to be actually called a team, people have to have clear shared goals. And that this doesn't mean that everyone has a goal, but they actually agree what the goal and the priority is. You have to work together closely to achieve this goal. So it's not a task that anyone can do or a subgroup can do. And the third ingredient is that you have to meet regularly to discuss performance and areas of improving your performance. So maybe your teams meet maybe 2 criteria, maybe they meet 3 criteria, but to actually be called a team, you have to meet all 3 criteria. Otherwise, we call these teams pseudo-teams. And working in a pseudo-team is actually quite stressful and it decreases the performance because the team cannot learn, the team cannot develop better ways of working together. And a critical way how the team can learn is team reflexivity. And what we see is that when the team doesn't reflect, they don't have this collective awareness. They don't have an understanding what's going on, where are we, how are the others doing. They don't have good strategies to collaborate because you may think you're supporting your teammate, but they constantly think, why is she doing it? But what is that supposed to mean? And they don't understand how it connects to their priorities. And then also you have to reflect on the environment you're working in, because oftentimes teamwork is hindered by physical barriers in the environment, by lack of communication technology, lack of IT connection, so you cannot really transfer the information. And reflecting on this and trying to improve it is really important. So when we think about the other way, what makes teamwork so difficult, it's usually that, and some of you may know this old story of the blind wise men that try to understand what they have in front of themselves. And everyone just goes and touches this elephant with their background, with their knowledge, with their priorities. And so you may come up with very different ideas of what this is, what the diagnosis for this patient is, what needs to be done. And it's very hard if these people are not only blind but also don't communicate with each other, to integrate it. So you may actually be treating two different patients without knowing it. So what people try to do now, and also try to do in healthcare, is to have these team huddles to get everyone on the same page. Like a mini briefing, we know it from sports. And in healthcare, I think most people think it's a bit ridiculous. You know, you don't meet up on the ward in the morning going like, yeah, we can do this. And if you would, it might just look a bit different. It might, everyone has different priorities again, and they're not just a team with the identical training. They hardly ever practice together before they go to a patient. So it's just a collection of people who don't really know what should we be talking about. Why should we huddle and form a team in the morning? But there's many moments actually in your day where you can do this, get everyone on the same page, where you have moments where you can reflect on performance. And usually teams do this in transition phases. So you don't do a lot of reflection while you're treating a patient, but while you're waiting for the patient to arrive, or when you're getting a handover from someone, or when people do checklist-based briefings such as the Safer Surgery checklist. So there are many moments where you can get everyone on the same page. But then while you're treating the patient, there may be little opportunities to synchronize a bit better what you're doing. So the next step would be in-action team reflexivity. So you can just say, I don't think this is working. The blood pressure is still dropping. So you can mention these observations to allow everyone to see what the situation is or how you evaluate the situation. But there's also opportunities sometimes to do little timeouts. And even in very event-driven environments, even if the patient is getting worse, there are little timeouts where you can say, okay, this is what we think it is, this is what we're doing. Does anyone have better ideas? This is really quick. And then, of course, after the treatment phase, you can do like an unstructured debriefing, hopefully maybe a structured debriefing, where you take some more time, especially if things didn't really play out that well. So what we can do is to help each other update our situation awareness and actually make it a shared situation awareness. I got some feedback yesterday after the decision-making lecture that I didn't really explain the situation awareness concept really well. And maybe that's right. So what I think is the most important part is that it doesn't help you if you are aware of the situation or if you think you have a correct mental model of that patient. As long as your team members don't have the same and you're not synchronized, your plan of action will not be very effective because people don't know why they are supposed to do certain tasks and why they're so important. It also helps the team to resolve conflicts because oftentimes conflicts in healthcare arise around certain topics like hygiene or following standard protocols. These are very, very common lines of conflict. And when we do a briefing, we can generate this common frame of reference. This is how we want to do things. Or you can establish in the briefing, if you see anything unusual, if I'm doing anything that doesn't make sense, speak up and let me know or tell me your concerns. And this way, the team reflexivity also encourages learning. A classic situation for this team reflexivity is the handover. Or it would be if we would do handovers in a way that we actually want to generate a shared understanding and actually transmit what you've learned of that patient when you bring a patient to the hospital to help them. And if the people in the hospital actually appreciate the information they get from the paramedic team and not just say, you know, we're pretty competent, so just, you know, get out of here, give us the patient, we'll get on with it. So there's many missed opportunities during handovers due to these assumptions, due to these territories, due to just being pretty confident that you know what's best for the patient, even if you haven't seen the patient for the last hour, even if you don't know everything about the history. And also, I think in this picture you can see it, we often don't have an ideal setting for handover communication. Somebody's under the bed trying to untangle the infusion lines, somebody's finishing the records, and then somebody else at the end of the bed mumbles something, and that's supposed to be the handover. So it's not ideal, and we don't give it enough priority, because then, you know, the handover can be really short, but it can be very effective. I'll just tell you, I'll give you a little handover based on one of the established handover structures. And some of you may know this already, you may know the house I live in, but some of you may not. So we recently repainted the house, and we did something that was a bit unusual because the house is white and we have all black shutters. It's a classic German family home with 3 floors. We have lots of windows overlooking the garden. It's outside Bonn, which is a small university town. And we have an excellent view of the surrounding hills. Some people there call it mountains. I would say it's hills. And you should really come and visit and see if the picture you have in your head now of what this house might look like is actually correct. Maybe you had something different in mind, because this house meets the exact same criteria, but it's just a little bit different, you know? And that's also what's happening when you're trying to convey the picture of a patient. In your mind, when you're telling them all the things, all the observations, all the background information, it's obvious what's wrong with this patient or what the patient looks like. Especially if you do that over the phone, it gets even more difficult because there's no visual cues. And I think we have made a lot of progress in handover research. And for once, people didn't look to the aviation industry, but they looked to the Formula One racing teams and looked at their changeover times at the pit stop. And the interesting thing here is that they have very, very clear responsibilities with very little room to maneuver. And they train it over and over and over again, and everyone knows exactly what to do. And what they did is they pretty much replaced the race car with a bed, a patient bed. So if you roll in the patient, everyone stands at the exact place, they know which part they play in the handover, what they have to mention in which order. And if they follow the protocol, it actually improved the quality of the handover without making it longer. And that's something that we often hear. Oh, if we would follow this protocol, we would be standing here forever talking about the handover. It's actually not. It doesn't make things longer. It just makes the information more concise and condensed. And another thing that they did, which I find really important, is before you start talking about the patient, everything is connected, the monitoring is connected, and then you do the handover. And I think most of you will have these kinds of procedures when you bring a patient to the trauma bay, that you do the handover, the initial assessment, and so on. So there's different structures. Some people use the S-bar or IS-bar. Some people use the ABCDs. Some people use the IPAS. I actually don't care which system you use. As long as you have a structure, you make it easier for the other person to follow that information. If you're jumping back and forth between things, it's just very hard for the other person to process that information, to remember it, and also to pick up any gaps, anything that they think might be important. What is probably one of the most important parts of all these communication structures is the last bit, a recommendation or a synthesis, something like your clinical gut feeling, what's wrong with this patient, what should you be doing? And then hopefully some readback, some questions from the receiving team. I think if we would do that, that's a good moment for creating a shared understanding. That's a good system for team reflexivity that doesn't take super long. The other thing, and you see this in many different situations, is that teams tend to get big and chaotic. So there is some basic psychology behind it that generally, if a team gets really big, for one thing, it's hard to see what everyone's doing. The other thing, and I picked the Scottish example in this case, is the Ringelmann effect, which is the effect that the more people you put on a rope or something, the physical energy they invest is less than you would expect by just adding up the energy of everyone. Because people tend to do a little less if there's more people. There's always a chance you may not be the one who has to intubate this patient. You know, there's somebody else who could do it, so I'll just stand back and, you know, maybe somebody else picks up the task. So that's something that we see really often, but there's also ways of managing this, and that's coordination. How do we actually make these decisions? Who does what? And in most situations, I just have these main dimensions. You coordinate information, you talk about things that are important for your decision making, and you coordinate actions to implement your treatment plan. And in many situations, especially in the trauma bay, it's been investigated in detail, there's a lot of cross-monitoring. So people looking what are others doing or what have others done instead of talking to them. And it helps you to anticipate the next steps. You see what somebody's doing, you see and understand what needs to be done. And you can also adapt your own activities to the pace of others so that everything goes hand in hand and is smooth. But if there's an unusual situation, you have to adapt. You have to increase the information sharing and planning, and you have to be very explicit about task delegation. So there's a shift from this implicit, we're all experts, we know how to do this, to a very explicit, lots of talking, and lots of information sharing to maintain this shared understanding of the treatment priorities. So what you usually have is some coordination anchors. You know, we do a handover from this step to the other, or we will make a decision once we get this diagnostic information back. So there's certain cues when you need to coordinate with others. But sometimes, especially trainees, don't know these anchors. They don't know when to coordinate. So it's quite important to make it explicit and say, why don't you just get ready, and before you intubate the patient, let me know so I'll come up and assist you. There are some templates, so you know when this happens, I can just start preparing this equipment, and that's just very routinized. That's something you just do without lots of cognitive effort. But at each coordination anchor, you have to see, is it still appropriate? Is this okay to move forward with it? And then in dynamic situations, you have to do this constantly. So it's not good enough to come up with a good plan and then implement it and hope that it just runs through smoothly. You constantly have these cycles of updating and maybe changing the plans, pulling a new template as you get new information of the patient. So the more emergent the situation is, the more dynamic the patient evolves, the more cycles you have to go through as a team. So it's really important that you do this explicitly. And we summarize some of these things I just talked about under non-technical skills. And I quite like this definition that actually comes from other industries, that it's the cognitive and social skills that complement the technical skills. So it's not just all about holding hands and singing Kumbaya. It's really getting your technical skills to the patient in the best possible way. And it's also something that you all have in some way or another, to some level or another. You can all make decisions. You can all assess a situation. But there's just some people who are consistently really good at it. And I think there's a lot we can learn from these people. So for different professions within healthcare, for anesthetists, for surgeons, for scrub nurses, for anesthetic technicians, there have been systems established to break down these behaviors into smaller observable behaviors so that we can actually rate the non-technical skills and tell people in the feedback what they need to improve on. And I've just picked the one for surgeons. I think there's lots of things you can see in your environment that are very important. Do you gather information? Do you actually put all the pieces together? Do you project what that means? Do you anticipate what might happen next to the patient? And also in the leadership category, setting and maintaining standards. That shows you that leadership is not just something top-down from the consultant level to the trainee. It's something that everyone can do by following standards and insisting on others following the standards as well. This is a recent study from surgeons, and I think it's quite interesting because they looked at years after fellowship and how the non-technical skills were rated. So this is not a longitudinal study, but how long were these people in training after the fellowship? And if you look at this, for example, supporting others, you have a peak when you finish your fellowship, and then it kind of goes down with more experience. The other is also implementing and reviewing decisions. Once you're an expert, you don't have to review your decisions, right? So it's quite interesting. And people said, oh, why is this? They're such good experienced surgeons, but probably when they went through training, non-technical skills wasn't a thing. Nobody talked about it. Nobody included it in the training explicitly. And also the expectation in their work environment wasn't that they would actually actively communicate with others and support others or justify their decisions. It was just something in healthcare that you're very much based on expertise. And once somebody has that level in the system, they're hardly ever questioned. So I think it's quite interesting, and it will be interesting to see how we can ramp this up, how we can increase the non-technical skills. And also, I think it tells us a lot about including senior staff in these trainings. It's not just something for trainees. I just want to focus on one skill, the leadership, especially during resuscitations. There is a study that I really, really like from a group in Switzerland led by Franziska Chan. And they studied resuscitations with, people arriving one after the other and the senior physician coming last. And they just looked at the high-performing teams and asked themselves, what do the senior physicians do differently in these high-performing teams? And the interesting thing was that their leadership was completely different. They didn't take over. They didn't run the resuscitation, but they supported the team to keep doing what they were doing. So the first thing, and a lot of experienced clinicians say it's actually a nightmare, because when I arrive, everyone's like, oh my God, good you're here, now you can take over. And it's actually important to say, keep doing what you're doing, and then just help the team to fill the gaps to improve their performance. So this supporting role is something that we often don't see. Everyone feels that responsibility and just jumps in, but it's actually the person with maybe the most experience, but the least understanding of that situation. And so you could say we have to train people to take these leadership roles. We have to run them through weekends and weekends in simulation. But what they saw in a study that they called a minimally invasive training intervention is that people actually have these skills. Everyone was able to lead the team during a resuscitation, but they didn't activate those skills. So what they did in terms of an intervention was to tell one person, by the way, during this resuscitation, you have to take the lead. And then they did it. So I think there should be some trigger in the environment that helps us do that. And of course, one of the first steps in a resuscitation is to establish leadership. But sometimes people just don't do it, especially if there's multiple experienced people in the room. Then it's really hard because, again, you could take the leadership role. Why should I do it? So if we have that opportunity, we sometimes step back and don't activate the skills we already have. I don't know, somebody might remember this movie. I have to admit, when I was a teenager, I loved the movie. I looked at it again, purely for academic reasons, and I have to say, lots of terrible haircuts. But in this situation, some of you may remember it, it's a locker room scene. And this one guy, this one guy had just done a very dangerous flight maneuver in landing his plane on the aircraft carrier because he flew really close to the tower, scaring everyone, but he was able to land the plane, and he thinks he's a hero. So this other guy, the former alpha on this aircraft carrier, says to him, I don't like you, you're dangerous. So this is something we would call speaking up. Telling somebody you don't play by the rule and you're risking everyone's life. I would maybe give him 85% for speaking up, because it's pretty late, it's already over. It's not in a way that is very easy for the other person to accept. So the conflict increases, right? It's not a way that the other person says, oh yeah, you're right, no, I'll never do it again, right? So, but then, and that's really fascinating, as the story goes on, this guy does another really dangerous flight maneuver. But this time, he saves the life of another pilot by guiding this pilot down to land safely on the aircraft carrier. And all of a sudden, he's a hero. And that's something we see in healthcare a lot. If you do something dangerous and it works out, you're a pretty cool guy or girl. If it doesn't work out, you broke like, I don't know, 100 rules and you violated this standard and this procedure and this regulation. So can we tolerate dangerous, reckless behavior when it works out? Should we evaluate it after the fact, or should we actually say, even if it worked out, this is not the kind of behavior we tolerate here? Anyway, great movie. But what we can see in healthcare, and this is actually a good report, is that not speaking up, not voicing these concerns, kills patients. They identified 7 areas where you should speak up. One thing is, of course, if somebody is about to commit an error, about to give a drug, even if you're not sure if this is the wrong drug, why not say something? Why not speak up and say, hang on, I'm not sure. There were 2 syringes there. I just want to make sure we don't mix things up. And I'm picking out something that people often don't like to talk about, which is incompetence. This is just the physicians having worries about the incompetence of a nurse on the top part or another physician on the lower part. What you can see is a huge discrepancy between the worries people have about somebody's competence and if they ever speak up, ever talk to that person, ever raise it, maybe not with that person directly, but with someone else. And if you look on the right-hand side, you can see this person has done something dangerous at least once a month. A patient has been harmed by this behavior. I think if you have that kind of knowledge and you don't say something, it's very risky for the overall system. And I know this is difficult. You're putting a relationship with that person at risk. But it's something that also tells us that speaking up is not just against the hierarchy gradient. Oftentimes when we talk about speaking up, people say, oh, but I'm a poor medical student and I can't tell the head of department that he's making an error. That's a huge gap. But think about you as a paramedic talking to your colleague you've worked with for 10 years about a sudden decline in his performance. All of a sudden you think, well, he's a good paramedic, but he keeps forgetting things. He's not really up to speed. What's going on? Do you talk about it? Again, there are certain communication algorithms that can help you do this. What I quite like is on the right one, the CAS algorithm that's included in the Team Steps training package, that you have this escalation model. You can say, I'm concerned, I'm uncomfortable with us doing it this way, this is a safety issue, so you actually escalate it. But what's also important to just start with your observations, to say, look, I just saw you draw up this drug. In my mind, this is not what the patient needs. What's your thinking? Why do you think we might need this drug? There's a chance the other person might be right. And you don't have to be super confrontational. You don't have to say, stop, you're wrong, you're making an error. You know, this is probably not the best way to have that conversation. Just give the other person a chance, but also give them a chance to discover that they were about to maybe harm a patient. So some of you may know this man, and he's probably not the guy who would respond well to this kind of behavior. So it almost seems like whenever I talk to people about speaking up, this guy works in their department. So whenever they say something, they get a response back from this guy. So what he says in some of the movies is actually quite rude, but not really overt. He's quite sexist, you could say. But he thinks this is just honesty. You know, you just need to tell people that they're terrible at what they're doing. And this is something that is tolerated a lot of times when people are good. When they're experts at what they're doing, we tolerate incredibly disruptive work behaviors. But this kind of rude behavior has an impact on performance. And I just want to mention the main result of this one study. If there's rude behavior, your performance goes down in 2 ways. First of all, you're less likely to share information. And I've seen many nurses, after a doctor being rude to the nurse will be like, you go ahead, doctor. If you know everything, then just do this. We'll see what happens. So not really supportive, not providing the information, but also the person or everyone is less likely to seek help. They feel less comfortable to say, actually, I've never done this before, could you show me again? Not if this guy was just rude. Even if he wasn't rude to you, if you just witnessed that rude behavior, your performance goes down. That rude behavior takes up so much of your energy, so much of your cognitive resources. You think you're still performing, but there's something in the back of your head going, I don't like this guy. So your diagnostic performance goes down if you don't have all that information, and your procedural performance goes down if there's not a lot of supportive behavior. So I think that's really, really important, that by being rude, you're not just being rude, you're actually putting patients at risk. So now I want you to think about you, bringing this back, because this is quite abstract, some statistical model. Just think about it for a minute. This is actually a very nice study from Denmark, and I think the results are quite fascinating. First of all, it's pretty stressful. Almost everyone agrees. And some people even consider a career change, mainly the ones early or very late in their career. Lots of people that I experience say, I'm leaving before I harm a patient. So far everything went fine. I'm trying to take another career spin. But what I find most interesting is that it makes people leave risky tasks to others. And maybe to somebody who isn't even aware that this is a risky task. So there's a lot of interesting motivational drivers that make us maybe not the best team players. And while there is usually the first victim, the patient that gets harmed, we hardly ever look at the second victim, at the clinicians that are involved in an incident or even traumatized by it. And then there's often third victims, because even the people who haven't been involved in that incident are often harmed because they think, my God, this could have happened to me. We don't have a good system to make sure these things don't happen. The next day, it could be me. So the impact, and I think the prevalence is quite interesting because there's a huge range, but I think the impact, the feeling of incompetence is probably worse than the negative emotional responses. But also the isolation. There are good studies that show when somebody harms a patient, colleagues don't want to talk to them anymore. Nobody wants to be affiliated with them. But what the people really need in that moment is that professional affirmation by somebody who's in the same profession. They don't necessarily need to talk to a psychologist. They need validation. Could you have gone wrong? What did I miss? It's more about technical aspects. And there's also, of course, a relationship to the severity of the error. The more harm that could have been done, the more stressful these events are. And generally, the coping strategies, I don't know if you learned any strategies for coping with this. Usually the rescue services are better. And I know many medical people that were involved in large-scale accidents or threats that say, I wish I was part of the fighting team, because they had their debriefing and we were just left out. Nobody talks to us. We're not part of that team, and we don't have that support structure. And the thing is that a lot of people report that they're trying to deal with it in a very ineffective way, and it just makes it worse over time. So I think when you say it takes a system to save a life, it also takes a system to support all the providers involved in these situations. You can do that by team debriefings regularly. The more you do it in routine practice, the less special and uncomfortable it is after a critical incident. And also, when you're supporting your team, they can support the patient and the family in a much better way. They are better prepared because they've gone through everything again. They know what happened, and they can have this conversation, the open discussion, much better. I've just put out some data from German hospitals. So when we look at the hospitals, they hardly ever have a system for supporting clinicians after involvement in a critical situation. In psychiatry, this is much better because they are very focused on dealing with suicides of patients. But this is a very limited spectrum, and generally, I think there's just a lack. When we look at surveys, I looked in emergency medicine, I just found things from pediatric emergencies, but I guess it's the same for adults as well. So a lot of people have never been part of a debriefing, and only in 50% of resuscitations there is some kind of debriefing. It's not very structured, and people also don't feel comfortable leading these debriefings because they don't have the skills, they don't know how to do it. They've never seen a senior conducting a debriefing. And the reasons given is usually we don't have time, we have too much to do, there is no quiet space where we could go and have a debriefing, and we have nobody who's qualified. So I think that's probably true in many environments. So I've come up with this from the literature. I've just come up with these tips. So I guess what it needs to be soon after the event, with all involved. And that's really hard. Sometimes, the paramedic team will have left by the time the patient's transferred to operating theater, and you can have a debriefing. I think it should be, everyone should be motivated to contribute. But if somebody's sitting in a debriefing and doesn't really engage, motivate them, but don't pressure them, because maybe there's something going on that they need to deal with in a different way. Also, I think it's not about who did what wrong or right and who knew it all the time, but I think it's more on the process. What happened? What did we do? What was missed? And then it could be guided by a protocol. And there are some studies that show even if the people don't have a lot of training, if there's a structure they can follow, they are more likely to conduct these debriefings. And I think there needs to be a summary. What are we going to take away? It's not just, okay, we talked about it, have a good day, but is there anything we can take away from it? Of course, this requires a certain environment. People have to be aware of the need for debriefings. Leadership has to support it. And there also needs to be the psychological safety to be able to do this. So it may take a while. But why not start with good performance? It's much easier to talk about things and to focus on the process and not to attach blame when things went well. And there's a lot to learn from good performance. How did we actually respond to this? What made us realize this wasn't working? Really helpful that the medical student made that observation, and give positive feedback to people, support them. And I think it's much easier to talk about this, and then it becomes a routine, and then you can talk about more difficult things as well. So in summary, I think you're all well on the way to becoming high-performing teams. Maybe you work in a high-performing team on Mondays, maybe on Wednesdays, I don't know. So what is important is to maintain that open communication. So even if you think this is so obvious, I don't have to mention it, maybe it's not obvious for somebody else because they were distracted, because they didn't hear that piece of information. Just try to share your understanding of the situation and the plan, and also what you think might go wrong. Oftentimes we try to neglect it for us, but also we try to hide it from others. If you want to sell a risky task to your colleague, well, better don't tell them about the risk. Then the reflexivity, I think there's lots of opportunities to start integrating that. And of course, as your day goes on, it gets more and more busy, and you have less time, and you want to go home, and always something else happening. But why not start with it in the beginning of the day? Why not, make sure everyone's on the same page, everyone knows how others are doing? And then also, I think the psychological safety for voicing concerns. When you talk to senior physicians or experienced nurses, they will say, I'm open for feedback. Everyone can tell me. But then you talk to the juniors and they go like, no, not her. I'm not going to talk to her about errors or anything. So open up that line of communication. Why don't you say, we've never worked together, but, as we go along, if I do anything that doesn't make sense to you, anything you don't understand, anything that you think might go wrong, just mention it and we can talk about it. Open up that line of communication early on. It is just much easier for people to then raise their voice. And it gets harder and harder to speak up the longer you wait. The closer somebody is to actually harming a patient, the harder it is to interrupt. And then I guess a system for debriefing and support after critical incidents is really essential to help people stay in that profession, to really say, I still like working in this wonderful profession because we're a good team, we're supporting each other, and we're learning from each other. So thank you very much.
Thank you very much, Tanja. Now we will open for questions and discussion, and Paul will lead the discussion.
I'm going to take privilege and I'm going to ask the first question. I'd really like to come and see that house in Germany.
Yeah.
It's very different to Scotland. So do we have any questions from the floor to start off? Then we'll go to Twitter. Right, but while you're thinking, so where would you start? You go in on Wednesday and you're not with the team you were with on Monday. Where would you start? What's your low-hanging fruit to start having that conversation to try and take somebody into that high-performing team?
Yeah. So I guess it's just the start of the day, how you open up. Does everyone meet in the morning? Do they have a small morning briefing? Or do they just, everybody just comes and starts doing their tasks, starts getting ready without actually being aware of the others? Just look each other in the eye once in the morning and say, hi, how you doing? How was your weekend? How was the conference? Just get that connection. And I mean, you probably think, but that's what we do all the time. When I do my observations, I see so many teams that just completely ignore each other. They just walk in and start doing things without actually appreciating what's going on. And on the other hand, you see people coming into the emergency department 10 minutes early and just have a wander around and say, what's the atmosphere today? How are we doing? Before I take the handover, I just want to see how stressed this nurse is. If this guy isn't back in this corner hiding, there was probably a conflict and he's not happy. You learn to read those cues. But why not make it a little bit more explicit and make it a shared thing?
Absolutely. And can that be done virtually? Because some teams are very spread out. We have teams that work within the hospital, but EMS, you might have, helicopter services, you might have 2 or 3 teams across the country.
Yeah.
You do it virtually as well?
Yeah, you can do it virtually, but you can also do it in the helicopter bases and then have a connection. If there's a structure that people follow, they know what to report back to the central level. In Switzerland, we had workshops with the helicopter bases that were quite interesting, where they just said, in the morning, let's not just do the briefing with the pilot. Let's do, how's the team doing? What are our challenges from the environment? Do we have any equipment challenges?
Yeah.
And what are we saying we can do today? And then they reported back to the dispatch center and said, look, if you maybe don't put us on anything this morning, we'll be dealing with the problems and then we can do it later. But they just had this kind of red, green, yellow.
Yeah.
And then they knew how they were doing. And it was really helpful for the teams to know where they are.
Is there anything else on the floor? over there. Gentleman over there. And the very dodgy Queen's Park Rangers top, but you'll only get that joke if you're from the UK.
Paul Kongstad, Medical Director, Skåne, Sweden. Thank you very much for a very interesting lecture. The sea rescue in Sweden, they have a very simple system. If you start a day and you're a 1, it's not very good. If you're a 2, it's okay. And if you are a 3, it's perfect. So if everybody is on 1, you shouldn't go out with the boat.
Yeah.
So that's very simple.
Yeah, I think
but that wasn't my question. I had another question, and that is that in emergency care, which I belong to myself, I've marked that many of us we want to make a difference. We want to make a difference to the patients, and if we are not able to do a difference, if a patient is not sick enough, we're getting a bit annoyed, sometimes bored. Is that kind of personality, that character, narcissistic character, is that something that disturbs the possibility, the capability to building good teams? Is that something you have looked upon?
Well, despite being a psychologist, I'm not too interested in personality. I'm more interested in behavior. And of course, if you have certain personality characteristics, it makes certain behaviors more likely. But because we can't change personality, I think it would just be like, you shouldn't go into that profession. But then you need people who are excited about making a difference, about wanting to help people. But maybe you need a system to balance that out. And a system of, speaking up if somebody's too much of a hero or kind of overtreats patient because he just thinks you can do more and more and more. I think it's something that's probably part of the culture, that it's still very cowboy culture. You just shoot from the hip, and if you're successful, then it's good. And maybe that needs to change a little, but it's a long process. And I don't think that, well, at least I don't know any system where there's like a systematic screening for certain personality traits, and you say, well, you would be the perfect, surgeon or emergency physician. You would have been perfect 30 years ago, but now this is not acceptable anymore.
Because there is two sides of the coin, and the narcissistic personality or the strain of that character is giving a very much of being eager to do something, and the real narcissist is possible to do everything just for having his ego boosted. So there is two sides of the coin, because there is much of energy in this kind of personality. Perhaps there are more of them in emergency care than in other specialties.
Yeah, but the thing is, you can make a difference even if it's not just for your own fame or your own ego. So maybe that's how you attribute that. I don't know. I've never really looked into it.
So one final question from Twitter, because it's coffee, and then we're going to go into our breakout sessions. Recruitment. Can we recruit into poor performing teams to make them high performing teams? Is this something we should think about when we recruit people into our teams?
I think, well, it's quite challenging, but you could think about scheduling. Who do you put together on a team? Oftentimes people like to work with people that think the same way they do.
Yeah, absolutely.
It just makes things so much more easy. But then you can have the super lazy team that just doesn't want to go out and go like, oh no, it's not going to be that bad. Or you can have the other team that are just, a bit overexcited about things. So, knowing that and factoring that in, I think is important. But there will always be a day where it doesn't work out, where you don't, you don't get the people, you can't schedule them together. So I think we need to have systems in place to compensate for these personality differences. And I think having these reflection loops, synchronizing everyone and referring back to standards and agreements, I think that's something that maybe helps more in the long term than the selection.
So, ladies and gentlemen, I wonder if you could help me in thanking Tanja once again.
Thank you.
Fantastically important and insightful session. So now we break for coffee. and then into your sessions for what proves to be a fantastic final day. Thank you.
Thank you.